Hi everyone. Thank you very much for joining another event from DEMA. And I want to also introduce one of our speakers who I want to also, first of all, thank them for joining and being able to do the talk. It is Dr. Katie who will be talking to us about understanding the systems and making a change on the systems that are already out there to also for you guys, especially those who aren't represented as enough in both in education and in research, are able to pursue that in as much of a representation as they can. Over to you, Dr. Casey. I'll let you formally also introduce yourself as well.
Thank you, Aidan. Appreciate it. I will just get my slides up. So, as was mentioned, my talk today is about understanding the system and making change. My name is Katie Nicol-Baines. My pronouns are she and her. I put my Twitter handle on the screen there. It's @KNicholB. Feel free to follow me if you want to see me generally ranting about this topic quite a lot on social media. I occasionally tweet other things that are generally quite equalities related. My current job at the moment is Equality, Diversity and Inclusion Manager for the Future Leaders Fellows Development Network. I'll tell you a bit more about that in the next few slides. I also co-chair the University of Edinburgh Staff Pride Network for LGBT+ colleagues and allies. That's a voluntary role alongside my day job, and I am employed here at the University of Edinburgh. I say here, I'm actually joining you today from my home office, and very pleased to be presenting to you. So I thought I would give you a little bit of an overview about myself to begin with. For anyone that can't see a photo of me or can't see me on the screen at the moment, I'm a white woman in my early 30s. I'm cisgender, I'm a queer person. Sometimes I use the term bisexual as well. I'm able-bodied and neurotypical, and I'm a woman. I put this as important features today because I think centering yourself, or at least positioning yourself around your identity, is always really relevant when we're talking about challenges and experiences. All of these features or characteristics that I have also shaped the way in which I see the world, how I interact with the world, and how the world interacts with me. And I just want to be quite upfront about who I am with you all today. I also, personality-wise, my therapist recently described me as a social introvert, which I believe means that I like socializing, but I need the time to be alone as well, and recharge my batteries. I love board games, quizzes, and I definitely have a borderline unhealthy obsession with American medical dramas. So if it exists and it's an American medical drama, I've probably watched it. Less so on the sort of soap opera-y side of things, but it's definitely becoming a bit of an issue. More specifically around my academic track record, I have a PhD in comparative physiology from the University of Leeds, where I specialised in muscle ageing and genetics, and was based in the malignant hypothermia research unit there. So if anybody is familiar with anaesthetics and the consequences of allergies to anaesthetics, that might ring some bells. But prior to that, I did my BSc and my Master's by Research in Human Identification at the University of Dundee. And that was focused primarily around anatomy and human tissue and surface anatomy for the purposes of forensic human identification. And alongside my research master's and my PhD and the time in between, I taught anatomy to medics, dentists, BSc programs, and also corporate groups that produce synthetic or prosthetic anatomical structures. And so I have had an extensive experience of interacting with medical students throughout their education, which has given me some insight into challenges and practices around medical education as well. I spent some time prior to what I do now working in big data, and did a human genetics postdoc at the University of Edinburgh, and I worked on big data at the University of Leeds. And so that gave me a really strong statistics background, and I will talk to you a lot today about data and how it shapes our understanding of systems and the different types of data that we might need in order to understand a system. My post just before the job that I have now was project managing a research grant on funding inequalities, and this has given me a huge insight in actually produce the foundation of the model that I will be talking to you about today around understanding systems. So when we think about access to research, who gets to do research, who gets to formulate questions, and who gets to participate, funding is such a huge core driver. Access to the capital gives you the power and influence to make decisions and shape the kind of research that happens. And so the insights that I got from this project have really shaped my understanding of how we understand systems more generally. And then finally, as I said at the top there, I'm an EDI manager. I will use EDI as an acronym throughout this. It stands for Equality, Diversity and Inclusion. I realize there are different versions of this acronym in different cultures as well, so I'm sticking with that one just for ease. And the Future Leaders Fellows Development Network is a career development network for research staff all across the UK. And my role within the network is to embed inclusive practices around research design, leadership, and management, all elements effectively of how we do research within this career development framework that we deliver for these fellows. And it gives me an opportunity to test out new things and try different ways of practicing when it comes to research. And I hope we'll start to have influences and we'll see these leaders carry forward these more inclusive practices into the system as well. So in the interest of time, I'm going to ask you all, this is designed to be a reflective exercise. So I don't like presentations to be completely just you sat there listening, because while you two take things in, I think doing is a productive thing as well. So if you have a piece of paper handy or and a pen, something to write with, a pencil is fine. Or if you just want to make notes, you don't have to draw pictures if you don't want to. You could just take out your device like a phone or something and write down the words that come into your head when I say certain phrases. But the main purpose of this is just for you to write down or draw the first thing that comes into your head when I read out a few phrases. It's basically a short story. When I do this in person, we get people to draw like a cartoon. We often do this in groups. But if you do want to participate, feel free to take out a pen and paper. I'm going to read out a very short story. The really key thing is that you draw or write down the first thing that pops into your head when I read out the statements. I will just give a couple of moments for you to find a thing to either write or draw with, or take out your phone if you're more inclined to type. Okay, so if you've all got something there, I've given a schematic here of how you might want to split up your paper. There's going to be 4 statements, and this is my sort of comic book style suggestion, but it is free form, you can do what you want. So the first part of the story is Chris and Sarah have been together for 3 years. So Chris and Sarah have been together for 3 years. Draw or write down the first thing that pops into your head. Okay. Next part of the story, Sarah works in hospital and Chris is a disabled artist. Sarah works in hospital and Chris is a disabled artist. Again, the first things that pop into your head. And if you do think of like embellishments, that's fine. But let them be the first things that are coming to mind when you're drawing your perception of the statement. Third statement, Sarah works night shifts while Chris goes out for drinks with friends. And the final part of the story, part 4, Sarah is expecting a baby and has been decorating the nursery. Sarah is expecting a baby and has been decorating the nursery. So you should now see a summary of the statements that I've read out to you, and feel free to be finishing your drawings, having a little think about what you've drawn. Now, in the interest of time, I'm not going to have a discussion at this point, but if people have thoughts in the chat as I'm going through this, please feel free to share. Again, this is a personal reflective exercise, so you don't have to share either. It's really just designed to get you thinking about the first kind of ideas that come to your head when you're told information about a situation. And this information about the situation has evolved, so you've been told more and more information. But the kind of things that pop into your head will be shaped by your own experience of the world. So here are some ideas of the kind of things that I've seen people draw when doing this exercise. So Chris and Sarah have been together for 3 years. Most people draw a man and woman, or some representation of a man and a woman holding hands or connected in some way. They might draw a little love heart to demonstrate the fact that they've been together, that there's a relationship there. I have seen a few people, however, often not the first thing that they think of, but sometimes they second guess themselves and they go, oh, Chris doesn't have to be a man. So it could be two women. Chris might be short for Christine or something like that. And so there's different things that could pop into your head depending on who you're used to experiencing in your life and the kinds of dynamics that you're familiar with. Sarah working in a hospital, I've seen this evolve over time, the kind of assumptions people make. Historically, when I've done this exercise with cohorts since the sort of mid-20 teens, if that's such a thing, a phrase, and often people assume woman name working in hospital, they think nurse. But I've seen more increasingly people don't assume that and they think, oh, Sarah must be a doctor. And I think that's influenced by how the kind of understanding of what working in a hospital as a woman is has evolved over time. However, with Chris being a disabled artist, I've not seen as much change. Most people still draw somebody in a wheelchair because that's kind of the imagery that we think of when we think about disability, particularly in the United Kingdom. Wheelchair symbols are our core symbol for disabled access and disabled opportunities in spaces and things like that. And the artist one I think is interesting. That's the one people tend to be a bit more fluid about. Often they draw a painter's palette, but sometimes they draw brushes, sometimes they draw sculptors and all that sort of thing. I have more recently seen people draw different representations of disability though, particularly as we become more familiar with concepts like hidden disabilities, which are represented by the sunflower symbol, and particularly also working with just more diverse cohorts. I've seen people who are disabled themselves, and so they might show, oh, well, maybe Chris is just deaf, or maybe Chris has a vision disability or something like that. So there's different ways you could represent this. Sarah working night shifts, typically see people draw a moon and a stars, something that represents nighttime. I think that's a fairly standard assumption. But you might see differences in people's experiences of that and depending on what hemisphere they're in, I suppose. Chris going out for drinks with friends, I think, is a deeply cultural bias, particularly if you've already assumed that Chris is a man. Typically, most people assume Chris's other friends are men and that going out for drinks typically means going to the pub. This is also a very British cultural thing and not strictly true, the only option that might be happening. And I think because the connection is between night shifts and Chris is going out at night with friends, we think of going out at night as being drinking alcohol. At least that's in the UK. But there are a lot of cultures in the UK where drinking alcohol at night is not the norm. And some people might draw, a cup of tea. It might not be beers, and it might be a mixed gender group as well. Or if you've not assumed that Chris is a man, you might draw lots of women, or two women, for example. And then this final statement around Sarah expecting a baby, the wording here is deliberate. So it doesn't say Sarah is pregnant, but most people assume to be expecting a baby means that you are pregnant. However, the more experienced you are with different ways of starting a family, it might be the case that they're using a surrogate or they're adopting. There's various forms and ways in which somebody might be expecting to have a child. And then the decorating a nursery one, people just tend to draw sort of paint pots and things like that. Sometimes people start to put in other threads of the narrative and they connect this statement to the previous one and they get cross with the idea that Chris is out having drinks with their friends while Sarah is busy painting the nursery and doing this work while she's in theory pregnant. And so it's designed to give an insight into your own biases. And actually a lot of this is unconscious. Some of you might have come across this term unconscious bias in the spaces that you move through. It's a challenging one. Everybody has it, and we kind of are not always very conscious of it because it is, like I talked about, my own positionality shaping my experience and understanding of the world. It influences you in ways that you don't necessarily always realize. It takes an awful lot of time to confront the biases that you have, think about them. You need to do exercises like we just did to try and think about what my biases are in the first place. And then actively doing things all the time to unlearn them or challenging them. It takes a lot of time and energy and effort. It doesn't work to just do one sort of random training that identifies the biases and points them out to you, you need to repeatedly learn and practice and address them, so that you're exposing yourself to different ways of thinking about the world. One thing that is true, and if you interact with more people, you'll become better at spotting bias in others than you are perhaps in yourself. And that's why it can be very helpful in high pressure situations to have someone else in the room to be checking what you're doing, checking the plans that you come up with, for areas where you might have failed to think about inclusion in a certain way. There's an interesting tool you can find online called the Harvard Implicit Bias Test. This is a long-standing psychological test where there's different ways of measuring your bias. And I know of people who have used it to kind of train or detrain themselves in different areas. I certainly have found that since doing it repeatedly, the one about gender is to do with associating women with the arts and men with science. And I now am pretty neutral in the way in which I perform on the test. And there was a period of time where I swung the other way, and I think of women in science and men in arts. So it's an interesting way of just getting a sense of where you are. I'm not saying it is the one tool, but it's an interesting thing to have a go at. It's a good conversation starter as well, with friends or family, to get an idea of what people are thinking. So why is that important? Well, we use bias in our understanding of systems, and also bias is probably one of the biggest features in why inequalities might exist within a system. So what I'm going to introduce you to today is this model for guiding systemic thinking, and it's centered around this sort of concept of an iceberg, where at the top of the iceberg is what you can see and react to, and it tends to be the most visible thing. And I will go through an example of that. Underneath the surface are the things that actually require more understanding and actually addressing to really cause change. So the event at the top might be, there aren't very many of X demographic in this situation, but under that, has that been the case for a long period over time? Has it changed in any way? Think about what has influenced those patterns and what the relationships might be between those parts. And then finally, at the very core, the base of the iceberg here is the mental models, the assumptions and beliefs, so biases, values that people hold about a system, and how do those beliefs keep the system in place and prevent more diversity, more inclusion. And I'm going to go through a couple of specific examples that relate to medicine and medical education to exemplify this as well. Other factors that you also have to include is the different parts that make up a system. So we have individuals that bring their own assumptions, beliefs and values into a system, and depending on the power you have, will influence the kind of role that you might play in guiding how a system works. There are institutions that form the parts of systems. They might be a system in themselves, and individuals are often a feature of institutions. There's the influence of funders, so where the money comes from and how the institution uses that money, and who has access to it has an important role to play. That links to government. Often government have a say in what funding is awarded to certain situations. In the United Kingdom, we have the UK Research and Innovation funding body, which is entirely government funding, and it's one of the largest scientific research funders in our country. And so the way in which spend and politics influences spend has an influence on the system and the kind of decisions that people are making or the kind of priorities that people care about. There's also an international context, and the two examples I will give today are from different situations, one from the UK and one from the United States. But I think we can't ignore the influence of the rest of the world on our systems in different places, particularly in higher education, where we welcome people from all around the world to our universities, and also, we have huge diversity in our population here in the UK due to movement of people around the world. So we're not these fixed bubbles which exist in isolation. And then the final thing I've added since the last 2 years to this is the notion of crisis and how crisis points influence systems in different ways. And we've seen how COVID has had a disproportionate effect on certain groups, and that the way in which crisis manifests for different people is shaped by bias and lack of understanding. And all of this comes together to form communities that we need to have a better sense of in order to make change. But none of this is very simple. This is they all link to each other, they all interact. And it's very, very difficult to think about everything all in isolation. But we can break it down in more comprehensive ways. So I'm going to start with an example from the UK, which relates to something that I have spent a lot of time thinking about through my advocacy in the LGBT space, particularly around trans rights. So this event that I'm using, this piece of data that is very current, relates to individuals. And I'm using this by way of example. So at the moment in the United Kingdom, trans people face a wait time on average of 2 to 5 years to access gender identity services. So these are the services that they might require in order to access hormones, therapy, support, potentially surgery at some point, in order to complete what is often referred to as a medical transition, but it is the medical support in order to facilitate their needs to achieve the recognition of the gender identity that they have. This is obviously a long time to wait for something that is so influential and transformative in your life. And in order to potentially address it, to make this wait time shorter, we need to understand what's happened over time. There is some data. So I found this data here, which shows a pattern and trend over time of the referrals to the main gender identity clinic in England from 2009 right through to 2019, 2020. And you can see it's gone up drastically. I believe it's something like a 14 times increase over this period of time, whereby we started out with around 70 odd referrals in 2009, 2010, and we're now up to close to 2,750 in the last few years. However, this is also coupled with extensive funding cuts to gender identity clinics. So this gives us some insight into why, despite an increase in referrals, there has also been a related increase in wait times, because there isn't the resource, there isn't personnel, there aren't enough clinics now to deal with the number of people who are being referred for this support and this service. And so then we have to think about, why is that the case? What has influenced this pattern over time? Why are there more people being referred, and why are the funding cuts happening? And that requires some understanding of the wider context around the government situation in the UK. There are things that have influenced the visibility and the rights of trans people. I've listed a few here. The first is Section 28, Clause 2A. This is more specifically about the teaching of different types of relationships and sexualities in schools. So until the early 2000s, it was illegal, or it was against. It basically, you weren't allowed to teach any other type of relationship in high schools other than heterosexual. Now, while this doesn't specifically relate to trans people, it did ultimately include them, because we were doing our young people a disservice and not teaching them about the diversity of sexualities and genders that exist in our country. In 2010, the Equality Act was an act of consolidating a lot of equalities legislation in the UK, and it affirmed the rights of trans people to people undergoing what is referred to in the Act gender reassignment, and gave them the right to not be discriminated against. And so it is potential that that has influenced increased referrals, because the stigma associated with being trans may have been somewhat alleviated by increasing rights and improvements in legislation. The Gender Recognition Act, which the date is missing on this slide, I apologise, it should say 2004, was also enacted around the time to provide the right to trans people to change their birth certificates to match their lived identity. And this is something that is also undergoing reform at the moment, which has prompted a lot of controversy, which I won't go into too much detail in. There's other things as well that underpin this, that relate to these mental models and assumptions and beliefs that people hold about the system. It was only in 2019 that the concept of being transgender was stopped being recognised as a disorder by the World Health Organization. So there's a legacy of trans people being stigmatised for having something sort of medically wrong with them, being disordered in some way, rather than being treated therapeutically and supportively. And I've put an allusion here to this notion of a binary understanding of sex and gender as a core belief that exists within this country. It's ingrained in our legal system. It's what we're taught in school. But I just want to prompt you to question whether that is enough information for us to be modelling our understanding of people's health needs, when it actually maybe fails to include certain people. So if we're thinking about making change in this context, we want to think about how we challenge the status quo. And I'm just going to prompt a few questions here to get you think about what terminology you taught in your medical curriculum when we're talking about sex and gender. Are you taught about reproductive systems, or are you taught about a genitourinary system? What is centered in terms of the purpose of the anatomy that you're taught about? When we talk about reproductive systems, obviously that includes all forms of reproductive anatomy, but actually for the vast majority of people's lives, the reproductive anatomy is not used for reproduction. It serves other purposes. And so what we center in how we educate really does send certain messages around what we value in terms of people's bodies. And then this notion of male or female anatomy, we talk about penises being male and vaginas being female, but actually what is more potentially accurate is that most people who are female have vaginas and most people who are male have penises. And if that were the starting point, it would give us more space to understand that there are people who are born assigned one gender or sex with certain anatomy that then ultimately doesn't conform with their lived experience of the world and their own identity. So maybe it would be more accurate to talk about gonadal anatomy in a more holistic and inclusive way. And a prompt, because I think this links to the efforts around decolonizing, is the idea around sex and sexuality and gender being a colonial idea. This idea of a binary gender is a very Western colonial construct that countries like the United Kingdom have enforced on other cultures. Are you taught about the notion of DSDs, which is defined as differences of sexual development? I prefer actually to say diversities because I think it celebrates it more. And I've seen some movements around using the term VSC, or variations in sex characteristics. And are you taught these as normal, part of a spectrum of anatomical sense, or are you taught them as abnormal and things that are exceptions to the rules? There's a very different way in which we can learn things. And then finally, is the way in which you're instructed in your clinical practice centered around cisgendered heteronormative ideas? Are you taught to check that every woman might be sexually active with a man and therefore could be pregnant? That those kind of assumptions can be quite limiting when you talk about reproductive or just general anatomical health of all women. Another example, because I'm just conscious of the time, and please do tell me if I'm running out. This is the other one I want to draw on, though. This comes primarily from data from a US context, but I believe is hugely relevant to the United Kingdom as well, particularly given the increased diversity in our population. And it's this notion that too many doctors are failing to diagnose people of colour correctly when it comes to skin diseases. So there's a consistent misdiagnosis, an increased rate of misdiagnosis in skin diseases on people of colour. It's very difficult to see the data over time because it's only really emerged very recently where that this is an issue, because people just haven't paid enough attention to failings around marginalised identities. But here's some information that I think is related to this, and it's the notion that if you look in dermatology textbooks, only between 4 to 18% of the images actually feature examples of skin disease on darker skin. A really recent example here is a handbook that was designed to show clinicians what COVID toes looks like, which was a rash associated with COVID-19. They produced this registry of over 700 images, which only showed 2% images of Black patients and 5% of Hispanic. Again, this is a US context here, so I'm using their terminology. But this is obviously a failing when we look at the data around who was most disproportionately affected by COVID, and the number of deaths was much higher in the Black and Hispanic community, particularly in the United States, but it was also true for Black and minority ethnic communities here in the United Kingdom as well. And this links to the other underlying structures that we perhaps also need to think of as being relevant, particularly around the idea that there's only, of dermatologists in the United States, only 3% of them identify as Black themselves. So who has the power to make change here and influence what people are learning about? And then finally, more broadly, there is a catastrophic underrepresentation of Black and other ethnic minorities in the healthcare system due to systemic discrimination and marginalisation. So how do we address this? There's some really great activities already ongoing. So a UK medical student, actually, Malone Mukwende, produced this resource called Mind the Gap, which you can visit. It's been downloaded nearly 250,000 times in over 100 countries, and it's developing a social platform as well to enable people with different skin conditions to get support and share their experiences. There's a US resource based on Instagram called Brown Skin Matters that was started by the mother of a mixed race child. And it's where you can submit photos of skin conditions and they'll be reviewed by a doctor before being posted with discussion and information. And finally, there's this initiative called Project Impact, which is designed to address racism and implicit bias in medicine. That's a conjoined effort between a group called Visual DX, the New England Journal of Medicine, and the Skin of Colour Society, where they're producing an image library that is now standing at about 28% images of dark skin to try and address this failing in the medical education space around this particular issue. Now, the examples I've given you today are just two very small specific areas in the system of medical education and healthcare that I've drawn on to exemplify this way of approaching a systemic understanding and trying to make change. And obviously change is happening at different parts of this iceberg. So it's designed to prompt your own thinking. I'm very happy to have discussion and take questions and think about the ideas that you might have that have come from whatever I've said today. So thank you all for listening. It's been a real pleasure to share these thoughts with you. And also it was a real great exercise for me to put this together. So thank you very much for the opportunity to talk. I'm looking forward to hearing any thoughts you might have.
Wonderful. That was absolutely great. Yeah, just resonating with as to what Katie has mentioned. Yeah, feel free if there are any questions.
Yeah, feel free to use the chat, or if you want to unmute or come on camera. I can see someone is typing, which makes me very excited. And I'm like, oh, it's like when you're waiting for someone to reply to a message and you see the blue dots. Someone is typing.
While that's happening, I don't mind starting off with the first question.
Sure.
I think the importance became more mainstream about misdiagnosing colored people when in the midst of the pandemic, especially how the oxygen meters, they weren't diagnosing people of color as accurately as they should have been if it was someone who wasn't of color.
Yeah.
And how there was a huge uproar. I don't know if that has settled down now, but yeah, I think that's what made it a bit more mainstream to people outside of medical, just the healthcare field.
And I think that's a really good example of how, like I put on the slide about the different features of a system around crisis, and how actually, while that was obviously a terrible thing that is happening and the medical system was failing those patients, bringing it to the attention of the public because everything was so public, in theory, generates more accountability. And so if you have power in the system to, I guess, weaponize that in some way and say, okay, look, people have noticed this to the point where everyone is standing up and saying we need to do something. In theory, it provides more of that evidence and that framework for people to be saying, okay, when I'm learning about this stuff, am I being told what oxygen deprivation looks like on skin that is darker, or skin that, different ways of presenting conditions? Hopefully it'll become part of the conversation and it influences change in that way. I can see there's a message from Anne Catlin saying, how do we make a difference as medical students in the way we are being educated and telling the difference between biased information and accurate information in our classes? I think it's a challenge, particularly as when you're in the position of students and you're potentially questioning an educator. It can feel like there's a power dynamic there, and there is one, because you are there to learn, and the general experience, at least for me anyway, in education, is that you respect the person who's teaching you. a good educator is always open to being challenged or asked for more information about why they're being told something in a certain way. And so navigating that can be difficult. So finding a constructive way of asking, do you think that calling reproductive anatomy is enough, when actually most of the time somebody who has a uterus isn't using that uterus for reproduction? You know, it can be a conversation and a dialogue, and prompting it. The other thing is as well, like, students do matter a lot to higher education institutions. So, you know, you can create your own forums to discuss these things, and make suggestions, and then think about the other parts of the system that have an influence. So when it comes to medical education in the UK, there's things like the General Medical Council or the British Medical Journal and things like that, places where you might have the opportunity to either present or make a suggestion, look for resources in different areas, and think about how you can influence in other ways, and just, I guess, collective action can be generated. I can see one from another person, Radu Alexandru. Thank you for this session, very insightful. You're welcome. I was wondering, do you think making those changes right now is worth it? The NHS is currently facing arguably worse problems, and backlog global warming, of course. And those issues are arguably more important to tackle. I'm referring more towards transgender sexuality related changes in the UK, but also racial diversities in countries of Eastern Europe, where those groups are relatively small, relatively speaking. I think it's a very interesting question you posed there, and I would summarize that around sort of thinking around a hierarchy of need in terms of challenge and what is possible. It's difficult to decide whether something is worth it or not worth it when presented with the evidence to something being very difficult. However, there is obviously a particular need when thinking about these kind of problems. So if I take the idea of backlog or global warming, we'll talk about backlog specifically because it does feature in the example around, you know, wait times for gender identity clinics. That is an example of backlog in one specific context. So what you could do is more think about backlog as the systemic issue, and then think about ways to address that. And that would be to do with funding in inequalities and lack of resource. And so ultimately, by addressing a bigger, in quotes, problem like backlog, it would have knock-on effects to the situation that I used in my example today. So I picked those out primarily because they're quite straightforward and easy to explain. They also were things that I found were to be of particular interest to me. I wasn't necessarily posing them as things that I think definitely should be on the agenda. But I think the idea of addressing what is in theory a bigger problem has the potential to create knock-on benefits as well. So yeah, thank you for raising that. It's very interesting. Another here from Lauren. Do you think it will ever be possible to decolonize Western medicine if many of its structural bias is inherently colonial? Don't know if that makes sense. Also, which is the best American medical drama? Oh, I love that. With both questions, excellent. Do I think it's ever possible to decolonize Western medicine if many of its structural basis is inherently colonial? Yeah, that's a big question, and it does make sense. I feel somewhat deeply unqualified to answer that in a totally full way. But something like decolonizing is such an incremental process. I'm going to defer back to a quote I once heard when somebody asked, what does equality look like? And the speaker said, the equality looks like the apocalypse. We've never seen it. And so whether it's possible is something I'm not totally certain of. What I am confident of is that change can continue happening. And I think the more we're willing to learn from other cultures and other practices around how medicine could operate, and the more open we are to change, the more likely we will start to properly dismantle those structures that perpetuate these sort of colonial ways of thinking about medicine. But yeah, sorry, that's a very general question. I can see Aidan is voting here for Chicago Med, which I do watch. I think currently my favorite is New Amsterdam, because it's set in one of the few public hospitals in the United States. It has a really cool jazz soundtrack, which makes it quite frenetic to watch, but also adds to the drama. And I like seeing how they challenge stuff. And they recently cast a deaf woman as quite a senior surgical role, and so you get to see lots of really interesting ways in which they include her in spaces and the way she works with her interpreter and things. It's just really nice getting to see like different people on my TV. It's not just all old white dudes. Hashtag not all white dudes. But yeah, thank you. Great questions as well. It's very interesting to be provoked like this. Any ideas on what feasible things we can work towards in order to change such an overarching systemic problem and reach equality eventually? Yes, so actually one concept I didn't draw out too much in the talk was also like where the information is in these areas. So one really small thing you can start doing is trying to gather the information in the first place. So collating data, looking for it, and if it is missing, figuring out how to get it. So what I did in producing the talk today was come up with, my tip of the iceberg first, and then go looking for the below the surface information. And in some areas, there isn't that much information. And so if you are in a position to do like a small project as part of your perhaps intercalated year, if you do that in your medical degree, or just a side project if you have the time, to start collating information about a particular area of systemic inequality, that can really be a really good starting point in forming this base of evidence to then trigger change, creating resources like that. And it doesn't just have to be quantitative numerical data, it can be a qualitative exercise. So you could think about talking with students in other parts of your institutions who are familiar with doing like interviews, talking to people in communities, going and actually trying to understand what they're experiencing can really be a really great start in improving our understanding of these kinds of challenges. And then once you have that information, it can form the framework for what you might want to do differently. And it might be that you discover things that are already quite simple that could make stuff better. Thinking about how, like, if we think about vaccine rollouts, one of the initiatives that was promoted was having vaccine centres in places like mosques or other community spaces where people are used to being or comfortable visiting in the first place, rather than expecting someone to come to a random part of the city that they've never been before, or in a very medical context where there's often the experience in certain communities of being mistreated by the medical system. And so things like that are small initiatives that can start to address different aspects of inequality. Actually meeting people on their terms, I think can be quite positive and productive. I will also admit that the show that I've watched the most is definitely Grey's Anatomy, because it won't stop, and I feel like I've committed to it and I can't stop watching it now, because like I would be cheating by, like, I'd be like giving up on a relationship of 19 years. It's like it's been going for 19 seasons. Yeah. And yeah. Do you think funding is a main issue, or is it more that people aren't making enough of these initiatives for systemic change? That is a very good question. I don't think it's one or the other. I think it's definitely a combination of both. So this is the detangling the different parts and how they all work together challenge. And actually, sometimes you can't fully do that. I think funding makes it difficult I think lack of funding makes it difficult to make the most of an initiative, because if you don't have the reach, if you don't have the resource for an initiative, then it just won't get off the ground. But then also sometimes it's a matter of funding being in the wrong place, or no funding at all, meaning initiative can't get off the ground anyway. And then sometimes it is the fact that we don't have the right initiatives, or we don't have the right backing to promote an initiative that is, challenging and problematic. So yes, very good insight there. Thank you for sharing that as well.
I'm going to ask us somewhat of a hypothetical, borderline philosophical question now.
Go for it.
On our most recent talk before this, we had someone who had more experience on global health and policy making in that regard.
Yeah.
And one of the key things that they mentioned were about the time frame as to the impact of how long on the implementation and the actual, I mean, essentially the greatest barrier becomes time.
Yeah.
And he was mentioning how exactly one of the key things is such as increasing education, which as a result has a byproduct on decreasing poverty and increasing decreasing any social inequalities at the same time. However, the reason why majority of them don't go onto that route is mainly because it takes a couple of generations to get to that stage.
Yeah.
And that's the main reason. So I suppose, let's say in the most ideal world where time is the only factor and you have unlimited resources and unlimited money, how would you tackle inequality, generally speaking? What is the one factor that you would think this is something that we need to focus on from the very beginning, and then we can work on others alongside with it?
I mean, I think, yeah, a huge part of it is, I think, the kind of standard assumptions and biases that we have about like who are supposed to fulfill certain roles in the world. So like if you get a kid, the average kid in the UK, to draw a picture of a scientist, they will draw an old white guy. And that comes from somewhere, that comes from the messages that we're fed about the world. So I would love to be able to change the kind of inputs that people are getting about what is possible, and what we see as being something you can do, and what that means. There was a really recent example of this manifesting. They're doing a huge review of inequality in science in Westminster at the moment, and an MP talked about how, made a throwaway comment, something along the lines of how, oh, well, women don't do physics because the girls don't like hard maths. And, you know, this just encapsulates the kind of bias that is fed to young people. However, then somebody made a really great counter argument I saw on Twitter, which shows how people from sort of Southeast Asian ethnicity are overrepresented in the medical sphere. But we then, as a consequence of that, don't assume that people of that identity are somehow better at medicine. So there's a bias, there's a racial bias there and a gender bias manifesting in two different contexts, where like if there's not enough women doing a thing, it must be because there's something wrong with the women. And if there's too much of a ethnic minority doing a thing, well, it couldn't possibly be because they're great at it. It's got to be something else going on. So like they can spot it in one sense because they don't believe in, well, they're basically white supremacists without realizing it. But in the other sense, they can't realize their sexism. And so it's all these combined factors that, if possible, if time was the only issue, in theory, they wouldn't exist. And so then we would just see things improving, I guess, if I were to think wishfully about it. And yeah, it's like, you know, can you create a perfect experiment where you have, you know, an equitable representation of everything, and then see how the dice fall, for example, or the you know, what plays out? I would argue that in theory, you would see people doing all sorts of different things. To go on a slight tangent around the money side of things, if money were no object, I think that would have a huge influence. And we see that in other spaces around economics, you know, people who advocate for the idea of a universal basic income, in the ways in which that's been trialed, you see people being far more creative and having more opportunities, because money is not a barrier to people needing to survive, to do the things that they care about. I'm not saying that it's ultimately not possible for that to exist in isolation, and there will always be other factors. But yes, very interesting to think about. Thank you for making me think. And I apologize for the tangents I got sent on there by my own brain.
Well, thank you very much for that. Yeah, I appreciate how difficult the question itself was. So it's just wanted to get your peace of mind as well. But yeah, thank you for that.
Yes, it's been a really interesting discussion, actually. It's prompted a lot of thoughts for me as well. It's always, there's no such thing as a selfless good deed. It's always good to do a talk and interact with a new group of people because it makes me think as well. So I really appreciate the opportunity. Thank you.
I want to express me also again, thank you very much, Katie, for doing this. It was equally wonderful and also equally as thought-provoking at the same time.
Great.
And yeah. And thank you very much for all the participants who came as well. Yeah, it was really lovely to actually answer you, read your questions at the same time. Yeah, once you have filled up all the forms, I will also send you all the recordings as well of this once they have been trimmed and finalized, along with the certificates at the same time. But yeah.
Great.
Awesome.
Thanks, everybody. I will be in touch.